Hey everyone, welcome back to my channel. So this video is highly requested. I'm gonna show you guys how to answer questions about drug addiction, intoxication, withdrawal. So let's get started. So one thing I want you guys to have in common with all illicit drugs, and that's the reason why they're addicted, is that all of them work on this pathway of dopamine release at the pleasure center called the nucleus accumbens. Alright guys, and this is the reason why they cause euphoria, and that is why people addict them. Alright, because the excessive release of dopamine in this nucleus accumbens along the mesocortical pathway is what brings the person to wanna reuse this drug again and again. All right, now whether these are stimulants or depressants or hallucinogens, they all cause the same effect on the pleasure center, and they all cause euphoria. However, they are different in their physical effects. For example, stimulants like cocaine, nicotine, caffeine, or amphetamine, these have stimulant physical effects by activating the sympathetic nervous system and releasing norepinephrine. They increase neural activity in addition to the euphoric effect. So in addition to euphoria, the person may be anxious and agitated, insomniac, with decreased appetite, and all the manifestations of sympathetic overactivity like pupillary dilation, increased respiratory rate, tachycardia, hypertension, all the way up to seizures. That's the effect of stimulant intoxication. Now, when the person stops using the drug, withdrawal symptoms are the complete opposite of this. It's as if someone was used to being active, and then suddenly when you withdraw something from him or her, they're gonna feel depressed. And this is exactly the effect that we see in withdrawal from stimulants. So withdrawal from cocaine, for example, leads to the complete opposite effect. So instead of pleasure and euphoria because of dopamine release at the nucleus accumbens, they will suffer dysphoria once they stop the drug. Instead of being hyperactive, they're going to be lethargic. Instead of having anorexia or decreased appetite, they're going to have increased appetite. Instead of having insomnia, there's going to be sleep disturbances, whether it's hypersomnia or nightmares, etc. All right, all this, guys, is because of receptor downregulation. Because when receptors are met or faced with a huge release of neurotransmitters from these stimulants, they downregulate themselves on the neurons. And so when you stop the drug, there's essentially less basal receptors than in a normal person. And so this person will be dependent on the drug. Now, on the other hand, depressants are another group of illicit drugs that also cause euphoria, but their physical effects are depressing rather than stimulating. And these include alcohol, barbiturates, benzodiazepines, opioids, and inhalants. All of these, guys, cause depressed mental status, respiratory depression, and kind of a relaxed state, unlike the stimulants. Withdrawal from depressants leads to the same effects as stimulant intoxication. It's the opposite of depression. So just imagine that withdrawal symptoms from a depressant cause stimulation, withdrawal symptoms from a stimulant cause depression. Now, a third group of drugs, guys, that share some features with stimulants and depressants plus hallucination are called hallucinogens. They also cause euphoria, and that's why people are dependent on them. And these include cannabis, a very well-known hallucinogen. Now, because these guys share very common features with each other, I will highlight to you guys what is specific for each. So once you see the word conjunctival injection or reddening, that means this person has just taken cannabis, all right? So reddening or conjunctival injections kind of specific to this drug, plus increased appetite and a perception of slow time. It's called, psychomotor retardation. This person is kind of relaxed, right? That's the effect of cannabis, which is a hallucinogen, which means this person, yes, will have hallucinations. Another hallucinogen that is kind of violent or dangerous is phencyclidine. Now, phencyclidine, guys, causes hallucinations in addition to analgesia, which means this person may not suffer pain, and for this reason they may be violent. They will have violent behavior, and it's actually life-threatening for this reason. It's a stimulant drug plus a hallucinogen at the same time. And a key feature that comes up in questions that you should consider, a key word, guys, would be nystagmus. Once you see the word nystagmus, you know they're talking about phencyclidine. All right. Now, other hallucinogens include LSD, and this is, it's not dangerous, but is characterized by visual hallucinations and depersonalization. They call it as if they went on a trip. And another hallucinogen is methamphetamine, or MDMA, which has the same features of amphetamine, the stimulant features, plus hallucinations. All right, so let's do some questions, guys, to reinforce that. All right. So first thing I do is read the last two lines and then the answer choices. So he's observed in the ER for several hours. His condition improves, discharged to the care of his parents. Which of the following is the most likely diagnosis? And in the answer choices, guys, we see some answer choices related to drug intoxication and poisoning or withdrawal. And we also see primary psychiatric disorders. And so it is key to differentiate primary psychiatric disorders from drug intoxication. So a 17-year-old boy is brought to the ER by his parents due to a recent change in behavior. He was polite and soft-spoken, but recently became intermittently, meaning sometimes and sometimes not. This is also characteristic of drug use rather than primary psychiatric disorder. Intermittently irritable, impatient, and rude over the past few weeks, all right? And they discovered he had stolen money and pacing in the room at 4 a.m. So unusual behavior, all right? When questioned by his father, he said, I have to be careful being followed by CIA agents. These guys are considered delusions, right? Now, he has no other medical conditions. Now, how could you differentiate that these delusions, guys, are due to drug use rather than a primary psychiatric disorder? If you look here, temperature at his vitals, they will give it away. All right, blood pressure is high, hypertensive, tachycardia, pulse is 124, and on physical exam, he's fearful, sweating profusely, and his pupils are dilated. Once you see physical signs and symptoms in addition to those delusions and behavioral changes, you know it must be due to an illicit drug use rather than, for example, bipolar disorder or psychotic disorder, right? Because if it's a primary psychiatric disorder, it will not cause those physical effects, right? And it would not be short term like this. He will mention previous attacks, right? But something that has been recent and intermittent, right? Plus those, huge physical effects means that this person is suffering illicit drug use rather than a psychiatric condition. The most likely here, guys, will be a stimulant drug because of these effects of sympathetic overactivity, and the only stimulant drug I can see here will be amphetamine. All right, moving on to the next question. Let's read the last 2 lines. A bilateral hand tremor is noted, and further neurological examination shows globally decreased reflexes. So we can see here, guys, some neurological symptoms. Which of the following is the most likely explanation for this patient's presentation? Again, guys, if we're talking physical symptoms, I'm going to exclude a primary psychiatric disorder because it can be explained by a medical condition, right? Now, from the answer choices here, we can see medical disorders like porphyria, SLE, Wilson disease, and we can also see drug poisoning and abuse like inhalant abuse, lead poisoning, or stimulant abuse. So is it a medical condition or is it drug abuse? Let's take a look. The patient's demographic is important. Her age, 13-year-old girl, is brought to the office by her mother due to abdominal pain. Now, this is non-specific, can happen with any of these. The mother says she's had occasional stomach aches for the last few weeks. All right, she thought it was menstrual cramps, but now she's losing weight. So abdominal pain and weight loss. Her mother also reports the patient's become irritable, locking herself in the bedroom, coming out only to watch television. So this is personality change plus weight loss and abdominal pain. Right. The patient says her mother is freaking out about nothing. She's fine. No nausea, vomiting, no change in bowel habits. And this, guys, excludes lead poisoning because lead poisoning is characterized by constipation, right? All right, medical history is significant for seasonal allergies. All right, now we can see here her pediatrician has noticed a 5-kilogram weight loss since her last visit. This is concerning. Plus, and this is a giveaway, guys, a flaky eczematous rash around the mouth involving the nasolabial folds. All right, guys, here involving the nasolabial folds. The abdomen is soft, no organomegaly, plus these neurological symptoms. Since we excluded lead poisoning, we're not going to be concerned about the neuro symptoms right now. And now let's exclude the other answer choices. Porphyria, guys, comes in attacks of abdominal pain, not like this, all right? And it does not cause weight loss, and it does not lead to the rash only involving the nasolabial folds, right? If it were cutaneous porphyria, it will be a rash that is sensitive to sunlight. Now, why not stimulant abuse? Because if it were a stimulant drug, it will cause abnormal vitals, right? This is one. Plus, there's gonna be agitation, anxiety that the mother will mention, and not just abdominal pain, right? Okay, now SLE comes with other symptoms other than these constitutional symptoms: weight loss, abdominal pain. It's systemic lupus, so there's gonna be, let's say, arthritis. There's gonna be the malar rash itself does not involve the nasolabial folds, it spares the nasolabial folds. There's gonna be, renal problems, or let's say other skin issues, so pleurisy, pericarditis. So it's not just about the rash, and the rash here is not typical of SLE. Now, Wilson disease could be, it's possible. However, it will present with behavioral changes and Parkinsonism because copper deposits in the basal ganglia. There's going to be history of liver affection, and this is not the case here. All right, so the only correct answer, guys, is inhalant abuse. Inhalants are hydrocarbons found in common everyday material like glue and gasoline. It's, found in household items that are accessible to this girl, and because these hydrocarbons are drying, they are gonna cause this rash around her mouth as she sniffs it. These are hallucinogens and stimulants at the same time, and their long-term use will obviously cause neurological effects and respiratory effects, etc. All right, next question. The last two lines say the patient's alert and restless. His pupils are dilated bilaterally. Bowel sounds are hyperactive, and neurological exam is normal. Which of the following is the most likely explanation? From the answers here, guys, it's mostly about drug withdrawal, right? Or lithium toxicity or neuroleptic malignant syndrome. Since I'm here between drug withdrawal symptoms, when I see pupils are dilated, bowel sounds are hyperactive, patients alert and restless, it must be withdrawal from a depressant, because these are stimulant effects. So it must be depressant withdrawal, right? So off the top of my head, I'm gonna exclude anything that is not depressant withdrawal. For example, it's not cocaine withdrawal, because cocaine is a stimulant, right? Let's see. All right, a 35-year-old man with a history of bipolar and substance use disorders comes to the ER due to depression, auditory hallucinations, suicidal ideation. So this person already has psychiatric problems. So I cannot guess right now. His medications include lithium and escitalopram, which is an SSRI. The patient has a history of 5 psychiatric hospitalizations, 2 past suicide attempts, including overdose, attempted hanging, has a history of almost every illicit drug abuse. The patient has been using multiple drugs, hospitalized, placed without precautions. We increased his dose of escitalopram to target his depression, this is an SSRI, and increased his risperidone antipsychotic to treat the hallucinations. His lithium level, he's telling you guys that it's within the normal range. So I'm going to exclude here lithium toxicity, right? On the second day of hospitalization, the patient reports muscle pains, abdominal cramping, nausea, and diarrhea, plus vitals that are almost stimulant effects, hypertension, alert and restless, dilated pupils. So these are stimulating effects. So it must be a withdrawal symptoms from a depressant, since he's been using all these drugs. So we already excluded cocaine, but all these are depressant drugs that may cause similar withdrawal symptoms. We need to pick the one most specific here. Alright guys, nausea and diarrhea with hyperactive bowel sounds is kind of specific to withdrawal from opioids. Now, alcohol and benzodiazepine withdrawal leads to stimulant effects. This is fine, right? But they do not affect the bowel. Heroin causes constipation, so withdrawal from heroin causes diarrhea, and this is kind of specific here. Because heroin or opioids are analgesics, muscle pain is also a specific withdrawal symptom here. And so opioid withdrawal is the correct answer. Why isn't it neuroleptic malignant syndrome? Because this would be seen with anti-dopaminergic drugs, right? And it will be characterized by hyperthermia, rigidity, and muscle breakdown. This is not seen here. Serotonin syndrome would be seen if the patient is taking 2 serotonergic drugs or more at the same time, which is not here. Now, opioids, guys, act on the mu receptor as pain relievers. They cause, instead of stimulation, they cause hyperpolarization and depression. They inhibit the action potential, causing analgesia and pain relief. And for this reason, withdrawal from opioids, because long-term use causes downregulation of these receptors. Withdrawal leads to hyperalgesia or severe pain. Now, other effects of opioids, because they have receptors elsewhere other than the central nervous system, causing depressed mental status and respiratory depression, they also have receptors in the eye, causing meiosis, and receptors in the bowel, causing constipation. And so this is kind of specific. So when withdrawal from opioids leads to stimulant effects, because they are depressants, plus the opposite of constipation, which is diarrhea, the opposite of meiosis, which is pupil dilation. So this is kind of specific. All right, guys.